everyone, welcome back to my page. Today I'll be discussing endometriosis. Thank you for subscribing to my YouTube channel. Thank you for following me on Facebook at OBGYN Talks with Dr. Ada Zion. Thank you. Today we'll be talking about endometriosis. Endometriosis is the presence of endometrial glands and stroma on sites outside the endometrial lining. The endometrium is inside the uterus. That's where the baby lies. That's where the baby develops. So, if you see any of the stroma or gland, that is endometrial glands, endometrial tissue outside the endometrial lining, inside the uterus, is said to be endometriosis. It affects about 6 to 10% of women of reproductive age, and amongst those coming for infertility, it affects about 35 to 45% of such women. It's one of the commonest indication for hospitalization in gynecological hospitalization of amongst patients that are coming for infertility. Now, it can be seen in different sites, different parts of the body. It can be seen in the reproductive tract outside the uterus. It can be seen on the ovaries. It can be seen on the uterosacral ligament. There's a ligament that connects the uterus to the sacrum. So we call it uterosacral ligament. It can be seen on the peritoneum, on the guts, intestine. Endometrial tissue can implant there. It can be seen even in the lungs. It can be seen on the liver, and it can be seen even in the brain. It can follow any pattern and be deposited anywhere, and is the commonest cause of chronic pelvic pain. What are the theories? The theories that have been postulated to be the cause of theory. The cause of endometriosis is not actually known. So it's a disease of theory. And each of the theories explain why it should be seen at the site they are seen. No theory explains why it is seen in all the sites seen. So one of the theory is, so among the theories are coelomic metaplasia theory. This theory is all about the development of the uterus. There's something that the uterus and some other parts of the body develops from one origin. And so this theory states that in those places like the pleural, the lungs, that is the pleural cavity where you can endometriotic deposit can be seen. That's why it's there is because they develop from the same origin. And so any stimuli, anything that causes stimulation of changes in those organs can cause endometrial tissue to be seen there. Now the second one is what we call menstrual regurgitation and implantation theory. This theory, let me explain it in a layman's term. What it means that in these places, for women that see their menses, as is people that when you start seeing your menses, some contraction may happen on the uterus. And what happens is that as the menstrual flow is coming out from the cervix, part of them are flowing through, regurgitating back, retrograde regurgitation into the tubes, fallopian tubes, and this menstrual blood will now go and deposit on other parts of the pelvis, and it will now lead to endometriosis. It can be deposited on the ovary, it can be deposited on the uterosacral ligament, it can be deposited on the pouch of Douglas, it can be deposited on the intestine, or any part it goes. So when you look into the peritoneum, there is the abdomen, you will see endometriotic tissue there. Now the other one is vascular and lymphatic theory, that these tissues, this endometrial tissue, that is the stroma and gland, enters the blood vessels and they are taken to different parts. And this story explains why you see endometriotic tissues even in the brain, and the person can come with symptoms suggesting that it's in the brain. So it can be taken to the lungs, can be taken to any part of the body, even the skin. Endometriotic tissues can be seen in some women on the skin, and this will give to this theory explain why it's seen in other parts. The other theories include induction theory, genetic and immunological theory that runs on families. So family history can be a cause, can be a risk factor for endometriosis. Now, when we go to talk about patients, the risk factors. Now, the risk factors are women or young girls, we call it early menarche. If you start seeing your period as early as it's not supposed to be, say a 9-year-old child, a 10-year-old child is already seeing her menses. So they said one of the risk factors is that early menarche. Start seeing your period early enough. Now, prolonged duration of menses. When the menses that is supposed to last between 2 to 5 days lasts beyond 7 to 10 days is a risk factor for endometriosis. Family history. If someone has a family history of endometriosis, the person is said to be at risk of endometriosis. Your sibling, your sister, or your mother has a family history, has a history of endometriosis. So it runs in families. Then other risk factors that we said is in favor, something that decreases it. Long lactation. But anything that will make you not to see your period. Long lactation, multiparity, there are risk factors for reduction of endometriosis. They actually reduce someone having endometriosis. Now, what are the symptoms and signs? A patient may come with just, I have pains. And you generally looking at the person, you will not see anything, but the person is coming with pain. Others that you will now be seeing blood, like someone may come, if the person has had surgery before, you may see the person bleeding from the site of surgery, the surgical site, every time, cyclically, that is every time she's having her period. So they come with any sign, any. So the signs and symptoms, the person will come with pains, chronic pelvic pain. In fact, dysmenorrhea is the commonest symptoms they present with. Dysmenorrhea means painful menstruation. It has two types, primary and secondary dysmenorrhea. The primary dysmenorrhea happens when the person will start having cramps and pains before the menses starts, and as the menses is starting, the pain is reducing. While secondary dysmenorrhea, which is mostly pathological, comes when the person has started seeing her period and the pain now increases as the period is coming. It's mostly organic in nature. And so endometriosis presents especially with secondary dysmenorrhea, painful menstruation, and prolonged primary dysmenorrhea. So instead of that primary dysmenorrhea, that pain that starts before menses, instead of it to wane, it enters and follows through menses. So they come with dysmenorrhea, they come with pelvic pain, waist pain, and the person may present with dyspareunia. Dyspareunia means painful sexual intercourse. The person will come with painful sexual intercourse, and sometimes it won't even allow them to be intimate with their partner or husband. So endometriosis can present with pain. In fact, pain is the commonest cause. Then bleeding from other sites at the site of those places. Someone that has the endometriosis implanted in the lot may come with inability to breathe well. Those that have it implanted in the brain may come with seizure. Those that have it implanted in the navel, you see the person, some like that is the navel, bleeding at the time of menses. The pains are actually cyclical, and they are every time the person wants to see her period. So cyclical means at the time the period is coming, the menses is coming, that site that their endometriotic tissue is deposited will start bleeding as well. So the person will come with pain. And before you know it, they will have, because it's something that is not supposed to be there, is a foreign something. For example, if it's on the peritoneum or on the gut or even in the liver, is a foreign something. So because it's there, each menses it bleeds like the normal menses as well, and inflammation will happen around that place. Then the next thing, it will heal by fibrosis. So before you know it, the person has what we call tight pelvis. The pelvis become fibrosed, as in you see adhesions if you open up. And how do you know that a woman has endometriosis? Is with these signs and symptoms. Next thing, we have to investigate the person. When we do transvaginal ultrasound, transvaginal ultrasound is limited, but it can give you a clue of what's happening. Maybe chocolate cyst, we call it chocolate cyst in the ovary. Give you a clue that there is chocolate cyst in the ovary. Give you a clue of one or two things. Now, magnetic resonance imaging, that's MRI, even though it's better than ultrasound, is also limited because it will pick big deposits, endometriotic deposits on other sites, but it may not pick those tiny ones that will be giving the woman problem. Then, the definitive diagnosis for endometriosis is laparoscopy. We'll do a laparoscopy. We'll look into the abdomen and you will start seeing the deposit. We use a scope, we call it is minimal access surgery. We don't have to cut you so much like others. We just look through and you will see the deposit on the peritoneum, even on the, you see, you look at that scope will help you look at the liver, the intestines, the ovaries, the pelvis, the patch of Douglas, those places that endometriotic tissues are deposited. So it will help you, and you can even use the same also to cure some, that is to treat it using diathermy or laser, depending on whatever is attached to that laparoscope. So laparoscopy is the definitive diagnosis. And what's the treatment? Treatment of endometriosis can be medical or surgical, depending on the grade. We grade endometriosis and we give it those with minimal symptoms, those with mild symptoms, those with moderate symptoms, and those with severe symptoms. For anyone in the medical field, understand what I'm saying. So we grade endometriosis. Some will have the endometriosis and they won't even know. Those with minimal grading may not even have any symptoms. Even if they have a symptom, it may be mild. Some people that have dysmenorrhea and just like dysmenorrhea, they will think it's just menstrual cramp, may have endometriosis without even knowing. So depending on the level of the severity of the symptoms, there is treatment. Those that medical treatment has to do with use of analgesics. We give the person analgesics, especially non-steroidal anti-inflammatory drugs. We give the person, it does some effect on the prostaglandin E2, which is released and is part of the causes of the pain that is associated with dysmenorrhea. So when you give the person non-steroidal anti-inflammatory drug and it's not working, we can go as much as giving some drugs, some hormonal drugs. We can even take over the person's menses. Our aim is to cause hypoestrogen level. We hypoestrogenize the uterus so that the effect of the hormone on ovulation and the effect on menses will be reduced. So we can go as long as taking over the person's menses. That's part of medical management. Then surgical management can be open, but now in third world, where there are no instruments or these minimal access surgeries are not accessible, you can do an open laparotomy. You see the deposits and you remove them one after the other. When these deposits are removed, the person, the recurrence rate may not be as much as it was before, but I bet you it may not be totally cured. We can, those that are no more interested in having babies, you can just take over the menses that I said before. Now, for those that have access to laparoscopy, we can do laparoscopy. With laparoscopy, we see the deposit and you use diathermy or laser and we bond them. We bond them during surgery. So we remove as much deposit as seen as possible. We remove them and most of the women will go on to get well. Now, for those that have completed their families, those that are not interested or the pain is so much and unbearable, they can remove their uterus, total abdominal hysterectomy, and bilateral salpingo-oophorectomy. Now, let's assume that one of the ovaries are affected and we decide to remove it and leave the other one. The recurrence rate from the other one may be higher. So, if a woman has completed her family, we can now do total abdominal hysterectomy, bilateral salpingo-oophorectomy, that is removing the uterus and removing the two ovaries. And we'll now give the person drug, hormones, get hormones to sustain the person, especially if the person is still young. Endometriosis can affect fertility. Remember I said amongst 30 to 45% of patients presenting with infertility may have endometriosis. And how does it do that? Number one, remember it causes dyspareunia and the person may not be able to have adequate sexual intercourse for fertility to occur. It can lead to because it's outside, because it's deposited in the peritoneum, with the inflammation, the healing by fibrosis that will occur, there will be adhesions on the tubes. The tubes will be adhered, even posteriorly. The fimbria end may be closed. The fimbria end is the end of the tube that grabs egg for fertilization. So if it affects the tube so much, it will lead to distortion of the tube and egg may not pass. It may even close the fimbria end totally, that egg may not pass. So it can affect fertility. Where it leads to, we call it frozen pelvic. It may lead to frozen pelvic. Everywhere is frozen. Something, the uterus that is supposed to be anteverted may be facing backward. That uterus is actually anteverted. So if the endometriotic tissue draws it backward, it will be in a wrong position. Now, it's if for a woman, that a young lady that is present with severe symptoms, and we talk about the person's menses, most of the things we'll give is even COCP. So you may take over the person's menses and the person will not be able to ovulate again. May give combined oral contraceptive pills, may give some hormones, or an effect to prevent ovulation and those hormones being released endogenously, so that the person will have a peaceful life, a pain-free life. So if we take over this, it has affected the person's fertility and the person may not be able to get pregnant. So endometriosis can affect fertility and it's a difficult one when it's affecting the person's fertility. Endometriosis should be managed. No woman should be having pains all through her life. If you have any symptoms suggesting that you have endometriosis, I advise that you present to the hospital and something will be done to help you relieve the pain, help you achieve fertility if that's what you desire, and help you live a pain-free life. If you have not subscribed to this level, please, if you have not subscribed thank you for listening. If you have not subscribed to my YouTube channel, please click the notification button, subscribe to my YouTube channel, share this page, share this video, invite your friends, follow my Facebook page or at OBGYN Talks with Dr. Ada Zion. I'll see you again tomorrow. Thank you.